Hello and welcome to the webcast titled Understanding the Healthcare Environment in Canada and Ontario. We have just a few announcements before we begin. The slides will advance automatically throughout the presentation. To enlarge the slides, click the Enlarge Slides button located above your slide window. Should you need technical assistance, click on the Help button. If your screen freezes or the slides do not appear to be advancing as they should, please try exiting and restarting the session as it may be an issue with your connectivity. At any time, you can submit a question using the box on the left-hand side of your screen. I would now like to turn the call over to Jen McNeil so that we can begin.
Thanks, Russ. Good morning, and on behalf of the Canadian Breast Cancer Network and GlaxoSmithKline, I would like to thank you for joining us this morning. Just a reminder that questions can be submitted throughout the webinar, so if there's anything you'd like to ask any of our presenters, please feel free to go ahead and submit them while the webinar is going on, and one of the presenters will answer them towards the end of the presentation. Our three presenters for this webinar will be Roger Chai, Bennett Lee, and Karen Chow. I'll just give you a brief history and background information on all three of them. Roger is currently the National Reimbursement Strategist, Specialty Care with GlaxoSmithKline Canada. He graduated from the University of Toronto with a Bachelor of Science in Pharmacy in 1980 and received his Master of Science in Pharmacy degree in 1983. He has extensive pharmacy practice experience in hospital and community pharmacy settings. He was a member of Ontario's Expert Committee, the Drug Quality and Therapeutics Committee, for 2.5 years. In addition, he worked as a manager in the Drug Programs Branch of Ontario's Ministry of Health and Long-Term Care for 5 years. Since 1999, he has worked in the pharmaceutical industry in stakeholder relations, government relations, and market access roles, and he's been at GlaxoSmithKline for 8 years and recently moved to his current position in 2007. Roger has volunteered in the pharmacy department at York Central Hospital, Richmond Hill in Ontario, and with the Kidney Foundation of Canada since 1999. The second speaker today will be Bennett Lee. Bennett has been with GlaxoSmithKline for 3 years as a manager in market access for Ontario public and federal public drug plans. He is also a graduate of the University of Toronto from the Faculty of Pharmacy and was an oncology pharmacist at the Scarborough Hospital prior to taking on a position at the Ministry of Health and Long-Term Care with ODB in 1997, where he managed the Section 8 unit. Also, while in government, Bennett Lee worked in the drug submission process, primary care reform, and in the Ministry of Children and Youth Services on early detection and intervention programs. And our final presenter this morning will be Karen Chow. In her professional role, Karen stewards national community partnerships in primary and specialty healthcare and charitable investments for GlaxoSmithKline. On the personal front, Karen contributes strategic marketing, fundraising, and governance expertise as a board member of the following charities: Actua, a national science education charity; the Darling Home for Kids, which is a home in Milton, Ontario that provides pediatric respite and palliative care for medically fragile and technology-dependent children; Lupus Canada, which serves to support Canadians living with lupus; and also the Credit Valley Hospital Foundation. As a member of the Quality End-of-Life Care Coalition and also of the Steering Committee for the Development and Implementation of a National Framework for Advanced Care Planning in Canada, Karen also actively advocates for policy change so that all Canadians may have access to quality end-of-care life. Karen is also a breast cancer survivor. So welcome, Roger, Bennett, and Karen. Thank you so much for joining us today. Roger, I'll turn the presentation over to you.
Okay, thanks, Jen. So for the next little while, we'll be providing an overview of the Canadian regulatory process and the reimbursement environment in Canada for oncology. And then we'll talk a little bit about how do we influence the environment, and then answer any questions and then close towards the end. So with regards to the regulatory process, I recognize this slide is fairly busy, but what it really does is it demonstrates that the process or the path that needs to be followed by a new drug to get from federal approval to the point in time when a patient can access the treatment because it's reimbursed is long and it's convoluted, and it does take time, and there are many steps in the process. Included in this process in the green box is the Patented Medicines Pricing Review Board. So this board ensures that prices in Canada are appropriate in terms of prices in an international basket. So I've mentioned that it does take time to get drugs from the time approved from the time we submit to Health Canada to when they're actually available to Canadians. And so this chart shows Health Canada's performance in terms of approval of new drugs and how long it takes to get those drugs through their process. And since 1998, 1998, while they have been improving in terms of their performance, and these are their targets of 355 days, they still are lagging behind that. So while it's encouraging that, from 2007 to 2008, that the time to approval has decreased somewhat, it is still lagging in terms of their own performance targets. And unfortunately, it seems to be a trend in the most recent years where, in order to meet those targets, they issue a notice of deficiency rather than because they're running out of time really to approve the drug. And basically, that target, they have to provide a decision within their own target. And so a notice of deficiency puts the drug in a second cycle review and adds another year to the review process. Not only does it take a long time to get drugs approved in Canada, it's over a year, add almost another year before we get public reimbursement. So, it typically takes about 2 years before Canadians will have access to a drug from the time it's filed to Health Canada. Unfortunately, within this year, not all drugs get approved for public reimbursement. And this chart, again, is fairly busy, but really the bottom line here is that if you look at those roughly 5 years, in any given year, only about 20 to 25% of drugs which are approved for marketing in Canada will actually receive provincial reimbursement. And when we look at, particularly at cancer drugs, and this particular data comes from a report that was put together for the Secretary of State for Health in the UK by an academic there, and just published in July of this year. It looked at 14 countries and basically ranked them. And this particular chart looks at the use of cancer drugs launched within the 5 years. And we see here that compared to the rest of the world, Canada was 13th out of the 14 countries that were ranked or were studied. And in response to this particular report, it's interesting to know that the UK, which was ranked 13th, has committed to spend another £50 million to increase access to cancer drugs. And New Zealand, which was at the bottom in terms of use of new cancer drugs, has pledged to improve access to cancer drugs as well. So then when we move on to the Canadian reimbursement environment for oncology drugs, it's a bit of a patchwork reimbursement, as I think most people are aware. There are patients who have private coverage, and then a number of patients who rely on public coverage. And there may be differences in terms of provincial reimbursement, and there's also an increasing trend in something called self-pay, and I'll touch on that a bit more later. We have a national review that's been in place for the last 3 years now. The Joint Oncology Drug Review was meant to be an interim process. 3 years later, roughly, it's still in place, but we anticipate that by the end of this year, we'll have moved to a permanent national oncology review called the Pan-Canadian Oncology Drug Review, or PCODR. And then further, in terms of oncology drug reimbursement, there are Ontario-specific processes for the submission of patient evidence, which Bennett will touch on a bit later. So Bennett will talk about private coverage.
Sure, that's great. Thanks, Roger. I have about 4 slides that gives a quick overview of private coverage, and from there we'll talk about quickly about some of the challenges that private insurers are facing. So overall, there are about 16 insurance companies in Canada, which covers close to 20 million lives. However, there are 7 key insurance companies that are available across Canada. And they are Sun Life, Great West Life, Manual Life, Medavie Blue Cross, Pacific Blue Cross, Desjardins, and SSQ. And so having a good relationship and contact with these insurance companies is critical to ensure expedited review of submission and oncology and specialty care products to ensure that there are no long delays for patients who require access to medications. And many insurance companies now are putting in restrictions like special authorization or pre-approval process on high-cost drugs to limit access to therapy and to save costs on their end. So those are things that we need to be aware of and to address them when they do come up. In terms of the delay process, it's similar, to public drug plans, though not as bad. So in terms of when a product comes to market, about 65% of private lives do have some type of coverage within about 60 days. And then between 60 to 180 days, additional 17% of those who have private insurance. And then about 18% of those who have private insurance may wait greater than 180 days to have access to drug or before a private insurer makes a decision on drug coverage. In terms of challenges in the private market, the issue here is that not all plans are alike. Even though there are 7 major insurers, each insurer would have different plans and different benefits depending on the needs of the employer and what they are willing to pay for. So not all plans are alike. There are more than 2,500 different plans for patients out there, and I would even say that there are as many different plans as there are employers, because there might be slight differences between what they want to cover, what's listed, and then negotiations with employees and bargaining agents. In terms of delays in listing on insurance plans, overall they're not too bad, but what we're seeing is greater delays with more expensive, high-cost drugs. The insurance plans are more familiar with the fact that public plans are not as quick to cover oral therapies, thereby shifting the cost of oral therapies to private plans, or as new technology or new drugs come onto the market that are oral therapy versus IV, which traditionally has been covered through the hospital setting or through the oncology clinics, for example, are now being shifted to the community or coverage by the private insurance. So more and more of these new technology or new drugs are being offloaded to the private plans, and they're becoming aware of that now. We're seeing certain reimbursement mechanisms like special authorization or pre-approval becoming more common with private insurers. So even though the insurers will say that they cover a drug, they may have specific criteria or barriers in order to review the drug before they're willing to pay for it. That way they ensure appropriate use and manage drug costs. But the last point that I have around here is around patients who have coverage may still incur high out-of-pocket costs as a result of co-pays or lifetime maximum. So, for example, if an individual who may have $4,000 per month in drug costs could have a copay as high as $800 a month, and that would be very difficult for any individual to pay. And so that could impact their ability to complete therapy or be on therapy long term. And often plans also have a lifetime maximum. And so a survey that has been conducted identified that there were 40% of the plans out there have a lifetime maximum of less than $50,000. So it really limits the amount and length of therapy that a patient could be on. So that's just a quick overview on the private market. And so we'll switch gears now and back to Roger regarding public reimbursement.
Okay, thanks, Bennett. So in terms of public reimbursement for oncology drugs, it is quite different from different areas in terms of different areas of the country. And reimbursement will really depend on the province you live in. It may also depend on the dosage form, so whether it's injectable or it's an oral drug. It may depend on certainly patient-specific factors such as age or financial status. But in general, the western provinces, the ones in green, they all have provincial cancer agencies, and all oncology drugs are covered for patients as long as it's in their formulary, whether it's an injectable or an oral drug. And the patients in those provinces for oncology drugs will have first dollar coverage, so they don't have a copay or a deductible associated with their oncology drug treatment. Manitoba and Ontario, which are in orange, the intravenous drugs are covered through the cancer agency. In Ontario's case, it would be Cancer Care Ontario, and the oral or take-home drugs, so a subcutaneous injection, for instance, would be a take-home drug. Those would be covered through the provincial drug plan. And then in the darker green, so Quebec and the Atlantic, the injectable drugs are covered through the hospital, and the oral drugs are covered through, or take-home drugs are covered through the provincial drug plan. So there is quite a bit of variability, as you can see. And if you're in a province where you need to be a beneficiary of the provincial drug plan, if you're in an oral drug, you may face more challenges in terms of trying to get access to that particular therapy. One of the things we've seen emerging, and this is not so new now, but in 2005, there was only one province in Canada where cancer patients were being charged or would have to pay if they wanted a particular intravenous drug that was not covered on the cancer agency formulary. This trend has really grown, and in 2009, almost all of the Canadian provinces, had a mechanism where patients could be charged for intravenous drugs which were not covered through either the hospital or the cancer agency. I wanted to switch gears a bit and talk a little bit about drug review and oncology drug review in particular. So we have as I mentioned earlier, we have the Joint Oncology Drug Review, or JODR, which was an interim process. When it was implemented in 2007, it was meant to be to have a life of about 1 year, but we're into 2010 now, and we're finally starting to see that it will morph into a permanent process called the Pan-Canadian Oncology Drug Review. So this particular slide shows how complex the reimbursement process is in Canada for drugs in general. So this slide will look at covers drugs regardless of the disease area or where it's used in. But essentially at NOC, the manufacturer can submit to the Common Drug Review, or CDR, and they review all drugs except for oncology drugs. Oncology drugs would go to JODR, or in future to PCODR. Quebec has a separate mechanism, so while they sit at the table for CDR and also JODR, they don't actively participate and are not bound by any decisions from those bodies. And then, as Bennett's talked about, we have the private plans. The three public processes, CDR, JODR, and Quebec, will all feed into a public reimbursement decision, whether it be through a cancer agency or the provincial drug plan, and then that ends up with a formulary decision. At the provincial level, CDR and JODR, the provinces have all agreed that, and the same will hold true for PCODR as well, the provinces have all agreed that if it's a no, they will not fund the drug or not listed in their formulary, and if it's a yes, it will be a maybe. So a maybe means that if the province can afford the drug budget-wise, then they will list it in their formulary. JODR and also PCODR was really implemented or built on certain principles that the provinces wanted to achieve. In particular, they wanted to get consistency across jurisdictions and across drug therapies. So in terms of consistency across jurisdictions, they wanted to try and eliminate the situation where a drug was available, an oncology drug was available in one province but not in another province. And they also wanted decision-making to be consistent between, a drug for heart disease or diabetes or whatever, and oncology. They wanted to ensure that the provinces had access to expert clinical advice, both from the clinical data and also the economic or pharmacoeconomic data, and then also access to guideline evidence in order to provide the best recommendation. But the key criteria they agreed on in terms of the review were clinical effectiveness and cost effectiveness. And they've been working through expert committees, and certainly PCODR will be composed of 5 to 7 oncologists, 2 pharmacologists, 2 health economists, 2 pharmacists, 2 patient representatives, a non-oncologist physician, and an ethics expert. So PCODR is sort of morphing from the Ontario process, or was Ontario-centric, to an expert committee with members from across Canada. And also, it'll move from just evidence and economics to adding also a consideration around ethics. This is the JODR interim process. I won't spend any time on this one except to say that really it was the JODR process was an Ontario-centric process, as I've said. So the Ontario CED was making a decision that would impact the rest of the country, while representatives from other provinces were allowed to sit in on the teleconference where drug reviews were being discussed. They were not allowed to participate in the discussion at all. So we will be moving from JODR to PCODR probably by the end of this year. And the critical pieces are really the changes from the JODR process. Have a kind of a blue star beside the box. So PCODR is going to move, will be an interprovincial or pan-Canadian expert committee, so moving away from just an ODB process. And also the Canadian Partnership Against Cancer will be providing support in terms of infrastructure support for this organization. So what's been the history with the interim JODR process? Well, up to the end of August of this year, of the publicly posted reviews, they have reviewed 27 new drugs or new indications for oncology drugs and have provided a list recommendation or yes recommendation in about 60% of those cases. But has this led to consistency of listing? Remember, each province participating in JODR maintains their autonomy in making the final funding decision. And I've talked about yes being maybe and no being no so far. If we look at the impact on public funding on access to oncology therapies, we see that there continues to be discrepancies from province to province. A patient can move from one province to another and not have access to a drug which is publicly funded in the province they've moved from. So we have a situation where, not all patients are not being treated equally still, and access to cancer treatments is variable. It's also not universal, as I've noted, in terms of if you move from one province to another, you may not have access to the same therapy. And that speaks to the lack of portability as well. It's also not comprehensive. There continues to be wide disparity in reimbursement across Canada, with some patients having reimbursement for IV cancer drugs, but not oral agents. And finally, it's not always publicly funded because of this increasing trend, or this trend towards self-pay for intravenous therapies that are not covered. So what are some of the issues with the current process and potentially with the P-coder process as well? Well, the requirements, as I've noted, they want consistency between disease areas in terms of reviews. Well, this requirement puts oncology drug or measures them against the same criteria used for primary care or mass market drugs. Well, is this really appropriate for oncology? In the past, oncologists were able to get access to drugs based on phase 2 data where there was a significant clinical need or there were just really no treatments for that particular condition. The review process currently really is built around having phase 3 data, so those large clinical trials. These take a longer time to conduct, certainly. And also, you may have challenges in terms of conducting those a phase 3 trial if it's a smaller patient population, or for late-stage cancer patients, there may not be enough cancer patients to really run a proper phase 3 study. In the past, efficacy data was all that was required for oncology drugs, and today we also need cost-effectiveness data. And typically, cost-effectiveness data, you really can't obtain it, or you can't run the models without comparative arms, so you need phase 3 data typically. And cancer funding continues to be all or none in some provinces. So patients who have exhausted funded treatments may have no options at all. Yeah. Okay, I'm going to pass it back to Bennett. He's going to talk about Ontario patient evidence submission, which is a new process.
Great. Thanks, Roger. Yeah, I just have 2 slides that will give a quick overview of the Ontario patient evidence submission. It's a new process that was introduced in April of this year to allow patient groups to submit information for consideration by the executive officer in Ontario. Patient evidence submissions could be accepted by registered advocacy groups for drugs on the drug review schedule. And so these are new drugs that that receive approval by Health Canada, and that manufacturers would put in submission through the Ontario drug review process. So during the review by the ministry's expert committee, the CED, then they would take into consideration the evidence submitted by patient advocacy groups. So the information that's submitted will be collated by the ministry and will be reviewed and presented by one of the patient members on the CED. And as part of CED's deliberation, in addition to looking at the clinical as well as pharmacoeconomic evidence, they need to discuss the societal value and have the patient perspective of the drug product. And so the executive officer, who is now Diane MacArthur, would make the final funding decision taking into consideration the recommendation from CED, as well as any information from patient groups. The next slide I have relates to, well, jump 2 slides, okay, the fact that with patient evidence submissions, it's a new process, so we're unsure in terms of how successful it's been so far. The timelines are very tight. So usually by the time a new drug product is posted on the website with specific cutoff dates, it's usually gives patient groups 1 to 2 months to submit information for review. So the deadlines and cutoffs are very tight. The other drawback is that patient groups need to register in advance as registered advocacy groups. And if you're not registered in advance, then you can't make a formal patient submission. In the submission, what they would like to see is a declaration of conflict of interest. They need declaration of authorship to ensure that it's not being written by a pharmaceutical company or another stakeholder with other interests. And in their submission, they would like to look at, in particular, impact of the disease and condition from a patient perspective. So, description of the symptoms and how that may affect quality of life or the patient's lifestyle. And there's another component where they would want to, if it's a patient-specific submission, they would need to know, what symptoms did the patient experience before? What were the previous drug treatments? Are there any other alternatives? So basically, a medical history that's a patient-specific rationale for the use of this drug or this new drug. So I've also included a web link that would provide more detail on patient evidence submission. And again, the question is, how successful will this be? It's good that the province now has a mechanism to consider patient evidence submission, but we'll need to monitor this and see how many patient groups actually make use of this process, and how successful is it in terms of having a more positive recommendation for new drug products. So this is something that we'd like to monitor and see a report back from the executive officer, probably in about a year's time, to evaluate the success of this program.
Great. It's Karen speaking. I'm just going to move into the next section. However, before I do that, I just wanted to sort of recap in that the information shared to this point in time has really been intended to provide you with an overview and also insights into the healthcare regulatory environment that obviously impacts Canadians' access to medical therapies and specifically treatments for cancer. In this next section, what we hope to provide are some practical tips and guidance on how to effectively advocate within this environment. So I think in conclusion, we can see that there are some key critical factors which determine funding decisions for new oncology therapies. And I think that what we're seeing is the current government processes really are trying to apply sort of standardized, an established approach, if you will, and a standardized approach to oncology products, which may work when you're looking at reviews and decisions around primary care products, but not so well necessarily for specialty care products, and especially those treatments for cancer. So what we're seeing is that is this really the right approach? So you look at what are the critical factors in funding new oncology therapies. Definitely clinical data. And what we're seeing is that the tendency and trend is to, on behalf of the government's decisions, is to see overall survival data, which we've articulated some of the challenges with. Also, pharmacoeconomic data, which is they're viewing as very, very critical. So, the cost efficiencies. And what we're seeing also is that is important in terms of a decision factor for funding for oncology therapies is treatment inclusion and guidelines. And that's something which physicians need to have control over and input into. And I think, the point I wanted to make on the first two, the clinical data and pharmacoeconomic data, that's something that the pharmaceutical manufacturers, in this case GSK, is responsible for. What is probably the unknown factor is the support that needs to be articulated and demonstrated from key stakeholders in cancer treatment, specifically physicians and patients. So if we look at, the environment that we shared with you and what's best in terms of effectiveness to influencing the environment, we know that the Canadian oncology landscape is changing and continues to change, and that more and more patient voices are growing, not only in volume but also frequency. We also know that over the past few years, just a few years ago, the federal government finally made a commitment to provide $260 million for the implementation of the Canadian Strategy for Cancer Control. And then subsequent to that, the federal government also established an arm's-length nonprofit agency, Canadian Partnership Against Cancer, also known as CPAC, to manage the implementation of that strategy. Now, this radical change has really occurred because of patient advocacy, and specifically in this case, and some of you likely were members of that coalition that used to be called the National Cancer Leadership Forum, now called the Campaign to Control Cancer, or C2CC. And that was really a culmination of 6 years of coalescing and agreement amongst key cancer patient groups, along with government officials and the pharmaceutical industry, to finally mobilize political will around cancer care. So we know that advocacy plays a significant role in changing the policy environment that impacts patients' care. So when we look at what are some of the key things, I think we've seen through the environmental scan that there are significant roadblocks in the scientific area and bureaucratic areas within the government. So what becomes important then is to knowing patients and physicians on how to advocate and who to advocate to, and this becomes pretty critical. So some of the key tips we would provide is that provincial ombudsmen, for example, and human rights areas and ministries are very important as target areas for advocacy, as are MPPs, both the current government and also opposition parties. And, of course, within the government itself, the Premier, Minister of Health, the Ombudsman in Ontario, and CCO, which, of course, is the Cancer Care Ontario, and a key advocacy ally organization, obviously, across Canada, and, of course, in Ontario is CBCN, the Canadian Breast Cancer Network. So here are some of the, practical tips that are sort of traditional and but are known to work in terms of how to advocate within this kind of environment. Would be to ensure that you package and position the objectives of what you wish to advocate for to be synergistic with the government's philosophies and mandates. So, i.e., ensuring the right patient receives the right drug at the right time, and using their language so that it can resonate with them when you're speaking with them. It's important to develop a key outreach strategy and ensure that you have some solid key messages and consistent key messages, backgrounder, fact sheets, and any other tools that are going to help deliver those messages. It's also critical to develop and implement a contact plan. We talked about some of the key contacts, but to really understand who are the key decision makers that need to hear the messages you need to deliver and want to deliver, the political staff of the Ministry of Health, Premier's office, the executive officer, in which case in Ontario we mentioned Diane MacArthur, and champions inside the government public service. It's also critical to create there's a typo here, I apologize, grassroots campaign, really working at the ground level with other colleagues to deliver those consistent key messages across the board, and also to develop and execute a political action plan to leverage your advocates' presence at political and community events. Some more tips would be just to be sure that your ask or your requests are consistent and constant, and that your efforts across that grassroots campaign are actually coordinated and customized to your audience. Do review existing research and determine if there's new data that's necessary to help you to make your messages robust. Prioritize specific objectives and make sure that they are not only prioritized but incremental, strategic, realistic, and ensure that you've assessed the credible intelligence so that you're not questioned in a way that you cannot answer when you're actually face-to-face with those requests. And it's important to ensure that you have a detailed government relations strategy and really determine the most appropriate offices to contact politically and also with the civil service. And just please note that both important for influence. So your key contact list can be developed based on that strategy. And really critical when you have all those tools in that you can then utilize them by securing meetings with the executive officer, the Ministry of Health, deputy minister, parliamentary assistants, and of course critics. And ensure you've got those standardized materials as a key turnkey package. You have a Q&A, a question and answer, fact sheet as background, and any documents for leave behind materials from meetings and requests. So that really sums up not only that section, but the entire workshop. And I'll now turn it back over to Jen.
Thanks so much, Karen. Thank you, Karen, Roger, and Bennett for sharing this information with us. I'll now invite audience members to submit any questions that you have to our presenters today. We'll just give everyone a couple minutes to actually type something in. You can submit questions by typing them into the bottom left-hand box at the corner of your screen. And then either Karen, Bennett, or Roger will be able to answer them for you. So we'll just give everyone a minute. Seems like you've done a fairly good job of explaining everything. We don't have any questions coming in at the moment. What I'm also going to do is on your screen you'll now see a pop-up for those of you watching, and it's actually just a quick survey. If you could take a couple minutes to fill this out as well before you leave the webinar. This will give us information that we can use for future webinars, give us any feedback about what you would have liked to see in the webinar, you've taken away from this webinar, what you thought was really well executed. So that would be greatly appreciated. And we'll still just give everyone a couple minutes to ask questions if you'd like. There is one question coming in, and the question is, will this presentation be available post-webinar? This will actually be available online at this link for the next 3 months, and then you'll be able to access it through the CBCN website. After that, it'll be archived under webinars there, so it can be accessed. So if you know someone who wasn't able to attend today, please share this link with them, and they can view the same webinar online. The other question we have coming in, are the slides available in print? Karen, do you want to answer that? Is it possible to make them available, hard copy of them?
When they're live or on the CBCN website, Jen, are they able to print from there?
You can, but what we can do, if it's all right with you guys, is I can send them out to everyone after, so everyone who's attended the webinar, I can just send out a PDF file of them.
Mm-hmm. Yeah.
Okay, so then we'll definitely do that. So everyone that was on this webinar and who had signed up for the webinar, I will email you a copy of the slide presentation later on today. Okay, it looks like that's it for now. On behalf of CBCN and GlaxoSmithKline, thank you everyone for attending. Roger, Karen, and Bennett, thank you so much for being available for this today and for sharing this information with us.
Thank you.
Thanks. Have a great day.
Okay, thanks, everyone.
Okay, bye-bye.